Welcome to another episode of On Target Conversations, a series about metastatic non-small cell lung cancer. My name is Rasheda Persinger, and I am currently the medical oncology lead nurse practitioner at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital, and I will be your host for this series. Today, we are talking about the utility of liquid biopsy testing at metastatic non-small cell lung cancer diagnosis to help enhance the speed of detection of actionable mutations. And joining me is Blanca Ledezma, who is a nurse practitioner at UCLA Santa Monica Hematology and Oncology Center.
Rasheda, thank you so much for having me on today.
Thank you for joining me. Before we get started, I should note that this is a promotional program supported by AstraZeneca. It is intended to provide educational information on the identification and treatment of patients with metastatic non-small cell lung cancer. We are speaking to you on behalf of AstraZeneca and have received compensation, but the dialogue is based on our personal clinical experiences on biomarker testing, including molecular biomarker testing. As I mentioned earlier, we will be discussing how liquid biopsy testing at diagnosis can be used to help improve the identification of EGFR mutations in patients with metastatic non-small cell lung cancer. Specifically, how medical team members may be able to support and educate their patients during the testing journey. To start off today's discussion, Blanca, can you share your experience on the role of liquid biopsy testing at diagnosis?
Certainly, Rasheda. Most patients with metastatic non-small cell lung cancer are pretty anxious to have their results and a treatment plan and are usually wanting to start treatment by the time they come to our practice. We had a situation where a patient came to us after they were diagnosed at an outside institution, but no molecular biomarker testing had been done. Unfortunately, obtaining the patient's tissue from an outside institution can take an additional couple of weeks on top of the 2 weeks needed for the molecular biomarker testing process at our institution. We ordered circulating tumor DNA testing, which helped us obtain the molecular biomarker results. This allowed us to make the appropriate treatment decision. Often, patients are evaluated and diagnosed with their primary care provider or pulmonologist. We frequently encounter patients that do not have enough tissue to perform molecular biomarker testing. We order liquid biopsy testing on these patients to help facilitate the results and make a treatment decision. Obtaining a tissue biopsy may delay obtaining results, and many patients are unable to undergo a tissue biopsy. Liquid biopsies have helped our clinical practice capture more patients with actionable mutations than with standard tissue biopsies alone, and for those who are unable to obtain a biopsy.
Great points, Blanca. In our clinic, the utilization of liquid biopsy testing has improved timing of results, identifying possible actionable mutations, helping to decrease potential delays in treatment. Prior to the routine use of liquid biopsy, we would sometimes wait 2 to 3 weeks for tissue results, only to have a negative finding or insufficient tissue. As we both know, given the heterogeneity of lung cancer, the lack of identifying an actionable mutation in tissue may still render a positive liquid biopsy result and vice versa. The patient would then have to wait an additional 5 to 7 days at our clinic for liquid biopsy results. Therefore, based on our experience and recent data, we utilize liquid biopsy most often simultaneously while tissue is processing. So Blanca, as you know, NCCN Clinical Practice Guidelines in Oncology, also known as the NCCN Guidelines, recommend molecular biomarker testing because first-line treatment decisions for patients with metastatic non-small cell lung cancer should be made based on biomarker test results if clinically feasible.
Exactly. Once the histology for metastatic non-small cell lung cancer has been confirmed, every effort should be made to establish the biomarker status. More specifically, NCCN guidelines recommend testing for EGFR, ALK, ROS1, BRAF, MET exon skipping, RET, NTRK, and PD-L1 in eligible patients with metastatic non-small cell lung cancer.
Yes, and targeted therapy for specific genetic alterations is recommended in the first-line setting for eligible patients with metastatic non-small cell lung cancer.
That's right. And for patients with metastatic non-small cell lung cancer who are identified to have EGFR mutations, EGFR TKIs are the NCCN guidelines recommended first-line therapy for eligible patients.
Since identifying actionable mutations is so important, patients should be made aware that treatment decisions may not be made until after they are tested for these mutations. Have you had patients question why they need to hold starting treatment? And if so, how do you discuss the importance of knowing all test results with them?
It's a great question, and yes, I do have patients ask why they cannot start treatment right away. By the time we see patients, they've seen various providers over an extended period of time and are anxious to get their treatment regimen started. It is important for patients to understand the need to know all molecular biomarker results prior to making any treatment decisions. Also, I prefer to set up realistic expectations from the start to ensure patients are aware that we may receive results for their PD-L1 expression status in approximately 2 days, but knowing the molecular biomarker status can take up to 2 weeks. If a liquid biopsy is done concurrently, we can have molecular biomarker results sooner than with tissue testing alone. However, in our practice, I stress that we usually do not make a treatment decision until we have all of the biomarker results. Knowing all of the results allows us to choose a first-line therapy that is FDA approved and is recommended by the NCCN guidelines.
Yes. And based on clinical experiences, we need to emphasize the importance of identifying the best first-line treatment option with our patients. During the current pandemic, we still find it important to emphasize the need to identify the best first-line treatment.
I completely agree. Patients should be aware that both tissue and plasma testing can be used to identify actionable mutations in metastatic non-small cell lung cancer. More importantly, if there's insufficient tissue to allow testing for specific genetic alterations, a repeat biopsy and/or plasma testing should be done. If these are not feasible, treatment is guided by available results, and if unknown, these patients are treated as though they do not have driver oncogenes. Also, the integration of liquid and tissue molecular biomarker biopsy testing at diagnosis has been shown to increase the detection of actionable mutations by approximately 17% over mutations found in tissue alone.
Precisely. Liquid biopsy testing should be integrated into clinical practice if a patient does not have enough tissue from their tissue biopsy to send for molecular biomarker testing, if a tissue biopsy is not possible, or if a quick turnaround time is essential. In such cases, liquid biopsy testing offers a minimally invasive approach.
Yes. Additionally, recent data have also demonstrated that in patients who did not have enough tissue from their biopsy, when they were tested by a liquid biopsy, approximately 28% of patients were found to have actionable mutations. In addition to patients who were unable to have a tissue biopsy, approximately 23% were found to have actionable mutations with liquid biopsy testing.
This information confirms that integrating liquid biopsy testing into clinical practice may help to avoid missing actionable mutations in patients with metastatic non-small cell lung cancer. However, there is another aspect of biomarker testing that can impact first-line treatment decisions.
Rasheda, would that be the variations in turnaround times for biomarker analysis?
Yes. Liquid biopsy molecular biomarker test results may be received sooner than tissue test results, with one study showing that liquid biopsy test results were received an average of 6 days sooner than tissue test results. This is important because, as we noted earlier, first-line treatment decisions are ideally made based on the complete results from biomarker testing, including molecular biomarker testing, versus the results that come back first. This is critical since molecular and immune biomarkers can overlap. For instance, up to 70% of patients with EGFR mutation-positive non-small cell lung cancer can have PD-L1 expression. More importantly, treatment decisions should be based on the EGFR driver mutation over PD-L1 expression.
Absolutely. We should convey this information to patients because immune checkpoint inhibitors with or without chemotherapy is only recommended by the NCCN guidelines as a first-line treatment option for patients with metastatic non-small cell lung cancer whose molecular biomarker status is negative for actionable biomarkers regardless of histology or PD-L1 expression levels.
Yes. And I think this can be an issue for our patients who find out their cancer is positive for PD-L1 expression and want to start immunotherapy with or without chemotherapy, but their molecular biomarker test results are still pending. Blanca, how do you talk to a patient who wants to start an immunotherapy, but their molecular biomarker tests have not been returned yet?
This is a great point you brought up. As previously mentioned, some results such as PD-L1 expression status can be turned around in approximately 2 days. However, the molecular biomarker results can take anywhere from a week to up to a few weeks under normal circumstances. As we just discussed, we know that there can be both a PD-L1 expression and an EGFR mutation in up to 70% of patients. Therefore, it is essential to inform patients and emphasize the importance of knowing all molecular biomarkers prior to making any treatment decisions. In addition, it is important to educate them that the FDA has not approved immuno-oncology therapy in the first-line setting for patients with metastatic EGFR mutation positive non-small cell lung cancer, and that the only FDA-approved treatment in the first-line setting is EGFR TKI therapy. It is important to inform patients that immuno-oncology therapy may be a treatment option in later lines of therapy, just not in the first-line setting if they have an actionable molecular mutation. Once patients are aware of all of the data and information, they are willing to wait as they understand the importance of having all of the biomarker results to make an appropriate treatment decision. Even during this pandemic, I continue to educate them on the importance of needing to know all their molecular biomarker results prior to any treatment decisions. Patients may be more understanding about the importance of obtaining all biomarker test results, knowing there's a possibility to receive an oral targeted therapy.
I completely agree, Blanca. As we both have discussed, I would ensure the patient understands the complete treatment landscape for lung cancer and the importance of having all results, including knowing their complete biomarker profile before initiating treatment. In addition, we need to reiterate to patients that identifying the best first-line therapy may improve treatment outcomes. It is important to inform patients that liquid biopsy testing is available and may provide more timely identification of actionable mutations at diagnosis.
Correct. It is also important to point out that integrating liquid biopsy testing could potentially help ensure our patients are receiving the right treatment for their disease by identifying more patients with actionable mutations sooner. As we have seen, the value of integrating liquid biopsy testing has allowed us to identify actionable mutation during these challenging times, especially when our medical system is greatly strained and our normal processes have been disrupted, causing delays in molecular biomarker results.
We definitely need to keep educating our colleagues and patients on how integrating plasma testing at diagnosis can help ensure patients with actionable mutations are not missed and are identified in a timelier manner to ensure patients with metastatic non-small cell lung cancer receive the appropriate first-line therapy. Blanca, thank you again for joining me today.
And Rasheda, thank you once again so much for having me on today.
I would like to thank our audience for listening and hope you will tune in again soon. To listen to more episodes of On Target Conversations, a series about metastatic non-small cell lung cancer, please visit the web address as it appears on your screen.